Good evening, everyone. I welcome you all for today's webinar on optimizing treatment outcomes in lung cancer, breast cancer, GI, and GU cancer. And with immense pleasure, I would like to invite Dr. Gunjesh Kumar Singh, who is Senior Consultant Medical Oncology at Paras HEC Ranchi, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Yeah, thank you so much. And good evening, everyone. Myself, Dr. Gunjesh, and I am a medical oncologist and leading the medical oncology department in Paras HEC Hospital, Ranchi. And I'm working in Ranchi since last 4 years. So today we are here to discuss regarding the various updates in the most common malignancies in our country, the breast cancer, lung cancer, GI, and GU cancers. So this session, this webinar will be of 2 hours, and we will be discussing these cancers on today, that is 15th of July and 16th of July. So thank you so much, all my faculties. Thank you so much, all the doctors who have joined this meeting and spared time from their busy schedule. So let's start. Handing over to our management team
Yes,
and to invite
thank you,
the
sir.
first speaker.
Thank you, sir. So, thank you for your kind words. So, our first speaker of the day on the session of breast cancer, Dr. Nihanti S., who is consultant medical oncology at Saroj Gupta Cancer Center and Research Institute, Kolkata, and she's going to deliver her talk on learnings from ESMO ESCO 2025. Over to you, ma'am.
Good evening, all. I thank Dr. Gunjesh and the organizing team for giving me such a wonderful opportunity to present here. So, without wasting much time, I would be sharing my own screen. Is it visible?
No, ma'am, not right now. Just share your screen. Yes,
Just give
it's
me
coming.
just give me a minute. Is it visible?
Yes, ma'am, you can go ahead.
Okay. So again, thank you for the organizing team and Zydus for giving me an opportunity. So without wasting much time, let's start the proceedings. See, as we all know that May was the tenure for both ESMO and the ASCO updates, and we have seen a lot of progress which has happened in multiple sites, and whatever the abstracts which are presented, and what did we learn from that? That's the main discussion and agenda of the entire talk for the day. So I won't be delving into a lot of things. My topic, I'll be focusing mainly on breast, and even in breast, the three important abstract which has been presented throughout, I shall be discussing. Are my slides moving? Okay. So let's start with the first one. As we all know, the Destiny trial, which has set a landmark. So the new kid on the block is the trastuzumab deruxtecan, which has shown a huge benefit in various settings of metastatic breast, or let it be gastric, or let it be in multiple sites of lung also. This molecule has shown a various benefit. But now, if you're going to use it in a metastatic upfront setting, let's see what is the outcome. So this is a study being conducted by one of my favorites. It's by Dr. Sarah M. Toleni. She's the head at Dana-Farber. So how did she do it? So before starting, I want to emphasize on the final key takeaway. When in a case of metastatic HER2 positive breast cancer, based with the Cleopatra trial, we all know that definitely a dual HER2 blockade showed a good PFS benefit. But in an upfront, if you're combining with a TDXD with the pertuzumab, they found out that there was a 44% reduction in the risk of disease progression. I'll be explaining in detail. So just a brief note and a pictorial representation. If you look into the comparative arms of TDXD with pertuzumab and the Cleopatra, there's almost 40%, 40 months PFS benefit seen in the Destiny 09 trial. So what was the rationale of combining this? We all know that the pertuzumab act on the HER2 and the HER3 dimerization, whereas the TDXD is an ADC molecule. So what both while combining, this has PER2 has actually increased the enhancement, the activity, the absorption, and the final outcome of the TDXD. It's more as a synonymous synchronous outcome which we have seen, causing the inhibition of the further down regulatory pathways. and even acting on the internalization of the TDXD molecule. So finally, what the various at the subclinical level, what they have found that adding PER2 to TDXD just increase the efficacy of TDXD. So with this, the outcome and the eligibility criteria of the trial, this was mainly used in HER2 positive metastatic breast, which had a 3+ or FISH positive patients. And even in a case of neoadjuvant setting, but the progression should be more than 6 months. After a DFI of 6 months, patients were included in this. So they had a 3-arm comparison. One was TDXD with placebo, TDXD with pertuzumab, and the other one was the Cleopatra THP regimen. The final endpoints was the PFS, and the secondary were the OS. And even here, they've compared the PFS2 data also. And the quality of life and the duration of response were also being taken into account. And other important thing to be taken into consideration is they even included the patients who were PIK3 mutant also. So I'll be explaining the number and the percentage in detail. So most important, this is an interim analysis data which was presented in the ASCO 2025 held at Chicago in May. So what did they concluded that the criteria for the superiority p-value was taken as 0.0043. And here there are 3 arms, but here the outcome of only the 2 arm has been given, not the one which is a monotherapy arm is yet to come, and final OS is still yet to become, and it's still immature. So we're not going in depth of that, only the PFS and the benefit which he has seen. So the number of patients almost screened were around 1700, but each arm corresponded almost equivalent to 300+ patients. And here, if you look into both the arms, here we are only talking about these 2 arms. The third arm, yes, we are not going to tell the data about it yet. So only the comparative arm and this, the Cleopatra trial regimen was used. So if you look into both the arms, the comparative arms were almost equal, looking into the ethnicity, the ECOG performance status, and HER2 status positivity, and the negative disease hormone positivity were almost 200 patients, and negative hormone status were 176, equally distributed almost in both. Important point to be kept in notice is here the low HER2 were not considered. So mainly it's IHC 3+ or FISH positive patients were taken into account. Equal distribution of brain mets and visceral metastasis were also considered. And if you look into the targeted, the kind of regimens which had received, yes, they had received TRAS2, PER2, and TDM1. This was equally distributed in both the arms, and that's what is to be taken into consideration. Coming to the PFS, which was the primary endpoint, if you look into the graphs of the Kaplan-Meier, which is very well separated with a benefit of 40 months versus the normal Cleopatra regimen. So this is the most important, which had shown a very clinical benefit. We all know that in a metastatic setting, we need a PFS, yes, and then maybe how it reflects into the overall survival. So this graph, which is quite well separated, shows that upfront usage of TDXD with PER2 than compared with the THP regimen has shown a significant PFS benefit. And even into the investigator assessment still shows that, yes, the graphs are quite well separated. And from the time, it has shown that there is a clinical meaningful improvement by adding the pertuzumab with the TDXD arm. We all know that various Destiny trial, let it be 04, we have used either in second or third line, which has shown a benefit even in HER2 low. This is the first trial which shows that upfront usage did show a multiple benefit. Even some of the patients where PIK3 positive mutations were also seen. If you look into this forest plot, it shows that all the patients, let it be hormone positive, hormone negative, PIK3 mutation seen, have done quite fair with the combination when compared with the THP triplet being used. And the subset which I would like to emphasize is more than 65 years. Yes, whenever you're using this regimen, this is the subset which didn't show any benefit. Most of the subsets did favor and did have a meaningful PFS in them. And again, if you look into the graphs which show the overall response rate and the duration of response, yes, there has been a sustainable significant response with the TDXD with pertuzumab in combination. So this says that we can obtain a persistent durable response. It's not only maintaining a PR or a CR, even a persistent durable response for longer time is important. So this indicates that usage in upfront shows a good benefit also. And yes, the one most important point to be kept into mind is OS, it's still immature. And so if you look into the graph, almost it's merging. So currently we can't comment anything about the OS. It's too early to comment. So let's wait. Maybe, by next year ASCO update, we would really know what is the outcome of this. So another important thing is PFS2. What exactly is PFS2? If a patient has been used upfront with some drug, and then in the second progression, you're giving the TDXD with this, did that show benefit or what exactly? Yes, and that also, this did make a difference in the PFS2 also. So if you look into the hazard ratio of 0.6 and the curves are quite well separated, yes, especially if a patient has been used to prolong the PFS, this can be used with a clinical significant improvement in PFS2 also. And now coming to the major concern, how are the adverse side effects and how are the safety profile? One most important complication, as we all know with TDXD, is the interstitial lung disease, which were reported quite high. But yes, proper monitoring, if patient complains any history of cough, dyspnea, or getting regular HRCT chest has shown a beneficial. If you look into the treatment discontinuation in TDXD with PER2 was only 79 when compared with a triplet. I really don't know the reason for this, but yes, the number is quite significant here. So this does say that the TDXD, definitely the complications rate, maybe because of the addition of docetaxel or anything, if we are not exposing any of the patient to chemotherapy arm. So maybe that's one of the other reason which says that the adverse side effects are quite less compared with the combination triplet regimen being seen. Here is the graph which again says that the adverse event, if which has been reported, it's quite comparable. And I think as all medical oncologists would agree that it's quite manageable. And all these things, until and unless it's a grade 3 or a grade 4, it's a severe life-threatening reactions where we don't want to use the drug. Rest all looks quite okay. So again, the main thing is ILD and pneumonitis. It's not quite significant as it was, as did we expect in these patients. Another thing we can say is maybe these patients were not upfront exposed to other regimens, or maybe they had a good ECOG performance. That is also another thing which we need to take into consideration. So what is the final take of this DESTINY trial? Yes, upfront adding in a metastatic upfront, definitely adding TDXD with a PER2 has shown a significant PFS. And the obviously we can't comment about the OS data. So it seems quite safe knowing all these profiles. I'll be talking about the critics of all these three things in the end of my presentation. So the outcome of this is definitely PFS has shown an increment and also an overall response rate, and also a the sustainable response, which we can see. The duration of overall response also was quite long. So maybe, yes, with the abstract, it seems quite significant. Now we are coming to the next abstract, which was presented, and that is on the SERENA-6 trial. We all know that camizestrant is one of the most important drug which we have used, especially it's a SERD inhibitor. If a patient has an ESR1 mutation, so what is the question we need to ask? Do you want to use this drug upfront, or do you want to use it on progression? Was the question which this trial has answered. So this was conducted by Dr. Nicholas Turner of Royal Marsden Hospital. So I won't be getting in detail of this because of time duration. The most important is we need to know that what is the mechanism of this. As we know that in a hormone positive metastatic breast cancer, whenever there is a resistance to the primary therapy, we do get this ESR1 tested. Now the question is, do you want to get this ESR1 tested upfront or on disease progression, which this trial is going to answer to us. So yes, definitely. Again, the main mechanism of action, it's a selective estrogen receptor degrader, highly specific, and even it overcomes the further resistant molecular pathways also. And focusing on the hotspot of ESR1, definitely it has shown a better response. A next generation, definitely showing a good degrade mutant inhibitor pathway resistance also. So coming to the background of this, so what did they do is upfront itself, they tested all the patients with ESR1 mutation. The procedure of testing was the liquid biopsy using the circulatory tumor DNA. And based on that, the patients who had the ESR1 positive, either upfront or on progression, were given camizestrant. So again, the number of patients used and were almost screened were 3,000, but the kind of population with ESR positivity was only 548. That's usually the 20 to 40% where ESR1 mutation has been seen. So these were the patients which were taken. And again, after progression or upfront, they were given this drug. So how did they divide? Mainly all patients were upfront being treated or upfront on treatment with AI with CDK4/6. They, whomsoever were subjected for the ctDNA testing on liquid biopsy, tested positive, were subjected to camizestrant, or the patients who progressed later who had a ESR1 were subjected to this. So that is why we do have the PFS2 benefit seen here. So again, the primary endpoint was PFS and the secondary were the OS and the PFS2, which was noted into it. So if you look into the baseline characteristics, almost it's comparable between both the arms, which I won't be explaining in detail also. So definitely upfront, the drugs which were used of CDK4/6 where Palbo was commonly used, followed by Riba and Abemaciclib. This was mainly based on the investigator choice of treatment. So one important note is the time of ESR1 mutation. At first, almost 54% were diagnosed. Most of the time, at least in our clinical practice, what we do is whenever patient is hormone positive, we start with CDK4/6 along with AI. And only on progression with this, we do get tested. So yes, definitely most of the patients, most of the investigators have also done the same thing. So here 47% for 73 patients were used at subsequent testing. But upfront, definitely almost 50% were used, tested upfront also. So the common mutants of the ESR1 were D538G, Y537S, and Y537N were taken into account. Again, the subgroup analysis of this has not yet come. So let's wait for it by next year, how the drug has evolved in all these mutation status. So if you look into the, again, the Kaplan-Meier graph here, which is quite significant, if you have the data of the CDK4/6, a PFS of 9 months versus camizestrant 16 months, definitely we would all vote for this drug. Again, we need to look into the availability of drug in our setting also. Again, the HR hazard ratio is quite significant. If you look at the hazard ratio, it's just been 0.44. So which is quite significant, especially in a clinical practice with well-separated graph being significant PFS. Definitely, it's a thumbs up drug to whether to give, not to give. We still need to wait as OH is still immature. The forest plot seems quite significant and it's responded quite well. Again, here the most important point to be kept in mind is I really don't know why patients who were prior exposed to Abemaciclib didn't do good. So this is another thing we need to ask, that why maybe if you look into further supplementary, or maybe once the trial is proposed in future and final we get hold of the supplementary copy, we really can check that why did the patients who did receive Abemaciclib didn't fare compared to the ones receiving Palbo and Ribo. Maybe one can be because of the number, because the number which was taken was quite small also. And other thing which, if you look into the mutation status, maybe the number is quite subjectable. All the mutation status have done quite fair well. Again, the other forest plot which seems quite significant is Asian population. Yes, we need to discuss about this is as most of the data subjects Western population, especially in Asian cohort, the number is quite less. So we really don't know what we can still wait for the entire trial and supplementary copies to be released. Again, if you look into the quality of health, definitely, which seems quite good. If you look into secondary progression, especially in patients who progressed and then received, again, in this also the hazard ratio seems quite significant and a quite good number. So it seems a beneficial and a good option. So safety profile seems quite safe with not major toxicity as could be expected because it's a specific selective estrogen degrader. So yes, definitely we don't have any specific major toxicity in all these cases. So if you look into the toxicity profile also, it's quite comparable and nothing major other than neutropenia, because the neutropenia can also be because of the CDK4/6 usage. Specifically, yes, we don't have anything in per se to be alarming. So final conclusion is switching to AI with camizestrant upfront or on progression seems beneficial, but yes, upfront seems quite worth. But yeah, in PFS2 also did show a benefit. So either way, this trial seems like, it has done quite good. As we all know that in a metastatic Hormone positive, we do have multiple options. Let it be either capivasertib or a PIK3 mutant, and inavolisib is other data which is coming up. So we have a lot of options, and especially maybe the hormone switching off with one of these SERDs or the SERMs may still show beneficial, and especially with camizestrant, it has shown a good, reasonable PFS outcomes. But most important thing is when to get the ESR1 tested upfront here. But again, in clinical practice, it keeps varying. So moving on to the next and the final discussion or the final trial, which I would be discussing today, would be the ASCENT trial. So we all know that, especially in a TNBC, ADCs, especially sacituzumab govitecan, has shown a good PFS and OS benefit. And if you look into the other immunotherapy arms, especially with the pembrolizumab arm, yes, with a CPS of more than 10, we do have a significant benefit. But if you're going to club both of them, so what is the outcome was being discussed in the ASCENT 04 Keynote D19 study, which the abstract which was presented. Again, this is by Dr. Sarah M. Tolini. So the major contribution is from them. So let's look into the detail of what it is done. So most important thing we all know, we do have a multiple option in hormone positive, HER2 positive patients. Even with low HER2, still TDXD remains an option, but especially in a case of TNBC. So what are the options? We do get the PDL1 testing, we do get the BRCA testing done, and we go for further tumor agnostic therapy. But combination of both these things, how does it work? Let's look into. Again, chemotherapy did show benefit of PFS, but adding with this, did it make a difference or not is the question which needs to be answered. So the main rationale is TNBC is quite aggressive. Most of this common scenario can be young patients. So adding and trying to increase the PFS or a duration of overall response is the main mechanism of action or main consideration as an oncologist. We all need to look into it. So we all know that chemotherapy benefit is somewhere between 7 to 8 months, adding an immunotherapy made from 9 to 10 or 11 months. So combining both, did it make a difference? So the trial previously, the inclusion criteria was that patients who were untreated, and more importantly is PDL1 assay, which was done by the DACO platform, had a CPS score of more or equal than 10. In all these trials, if you look
I would request you to conclude your presentation.
Yeah, okay. I'll just take 5 more minutes and I'll end this. So I won't go in detail about this as we are running short of time. So I just want to show that definitely there is a PFS benefit which is being seen. If you look into the comparison of both the sacituzumab with immunotherapy versus any chemotherapy or anything alone, definitely the PFS has shown. And most importantly, there's 35% reduction in risk of disease progression, which we all need to look into it. As I don't have much time, I won't get into depth of everything. Definitely, combination seemed a beneficial outcome. And even there is a sustained duration response also has been noted. So adverse effect, again, it's the same IREs, which which is well handled. So not major concerns. So which can be taken, and anything more than 20% or in both the groups were quite well handled also. So coming to the conclusion, definitely combination did show a benefit of 11 months versus 7.8 months if in the comparator arms. Most importantly, OS is all immature for all these things. So I would like to conclude my talk. So this was the presentation. Definitely it shows a good benefit. But what are the criticisms? If you look into just the TDXD Destiny trial, most importantly is we don't know the benefit was added by PER2 or the TDXD alone arm. So we need to still compare the monotherapy data, and only once the final monotherapy data which says that yes, TDXD versus TDXD plus PER2 did show a difference, then we can do it can implement in practice changing. Other most important thing is the sequence of ambiguity. Like if a patient is going to progress upfront, if you're going to use TDXD, what are the other lines of treatment and how is the protocol and how are we going to change? This question needs to be answered. That's the optimization based on post progression. Definitely, we know that all these patients are going to progress. So obviously, we're going to maintain a sustained duration of response. But post progression, how is the approach needs to be taken into account. And the second, regarding the second trial, that the SERENA-1, looking into the ESR1 mutant subset, it's only a smaller subset, only 40% taken into this. So with this, do you want to test ESR upfront? Again, looking into all the logistics and all the other aspect, we need to answer this per se, and how needs to be, the question which has to be answered is the long-term endocrine sensitivity. How should we assess? Upfront, if you're going to use a SERD, maybe usually in practice, we use it in a second or a third line when patient has been progressed on an AI. Upfront, you're going to use, and if patient is going to progress, we really don't know the answer. And finally, regarding the Accent and the Keynote trial, if you compare both the combination, there was a significant benefit, but we don't have a monotherapy arm. So everywhere, if you look into it, we do require a monotherapy arm. And we really don't have any biomarkers for ADC. So did the sacituzumab govitecan is acting, or is it the immunotherapy which is combined? We really don't know. So these questions need to be taken into consideration. And maybe in future, once with a longer follow-up data, with a longer OS mature data, maybe we can do say that these all trials, especially these three, might be practice changing. So with this, I would like to conclude my talk, and I thank the organizing team for giving me an opportunity. Thank you so
Thank
much.
you, ma'am. Thank you so much. There is one question in the chat, ma'am. You can answer that. Till then, we will start a panel. And for the next session, which is a panel on management of TNBC. And for this, I would like to invite to moderate the panel Dr. Shikhar Kumar, who is consultant medical oncologist at Yashoda Hospital, Hyderabad, and request sir to invite the panelists.
Thank you, Dr. Gunjesh, my very dear friend, for having me on this wonderful virtual meet. And I would request my panel to quickly switch on their cameras and be available. Dr. Satish Sharma, are you there? Dr. Satish Sharma?
Yes, Dr. Satish sir is there.
Dr. Kumar,
Man-
Dr. Kumar Saurabh, sir?
No, sir. He is not available.
Dr. Manavi is there?
Yes, sir.
Dr. Satish's camera I cannot see. Dr. Manavi, are you there?
Hi, sir. I'm there, sir.
Hi, Manavi. Nice to
Yes,
see
sir.
you.
Yes,
Dr.
sir.
Dr. Rajnikanda and Gunjesh is there, obviously, yes. Okay, so we have
Ma'am is not there. She's joining in sometimes.
okay, so we have Satish, Dr. Gunjesh, and Dr. Manavi, right?
Right.
Okay, so I will quickly start the panel. Of course, this is something which is just a chat. It's just we'll just have a discussion and see how each one of us we approach triple negative breast cancer. Of course, Gunjesh gave me very little time to prepare for this panel discussion. So I just took two key topics which I felt that merited some discussion. One is, of course, the current standard of care for early triple negative breast cancers, that is Keynote 522 approach. And we'll look at some nuances in this subset of patients and see how each one of us differ from each other in managing these patients. And of course, now Dr. Nihanti has very nicely presented the Ascent 04 data. So we'll just try to break down that data a little bit more and see if we are in agreement with the way the trial was designed and what the outcomes were. So coming to the Keynote 522 approach, see, we all know that Keynote 522 has been established as a standard of care for early triple negative breast cancers. Just to recapitulate, it took patients with either T2 or above primary tumor size TNBCs or T1C, provided they were node positive. So basically what I want to show here is T1C node negative were excluded from this trial because of the perceived low risk of recurrence in these patients. And then, of course, we all know the randomization between Taxol platinum and AC or EC or the same backbone with the addition of pembrolizumab, both in the neoadjuvant and in the adjuvant phase, with the endpoint of PCR as well as event-free survival. And overall survival was a secondary endpoint, which is to be kept in mind. So we all know this protocol. We all treat our patients with this protocol. So now coming to the important question is, if in the clinic you come across a patient who does not meet the criteria for the Keynote 522 as per the textbook. So clinically T1C and N0, because this happened to me a few months ago. And then again, I was in a dilemma whether to offer this or not. So I just want to know from my panelists that what would you do in this scenario? And if the case is referred to you for neoadjuvant therapy, your surgeon is kind enough to refer it to you for neoadjuvant treatment, then what do you do? So we can start with Dr. Gunjesh, and then Dr. Manavi and Dr. Satish can also pitch in one by one. Gunjesh?
So thank you, Shikhar. I think in recent St. Gallen this conference, and they have shown that the most of the time the medical oncologists are more preferable using neoadjuvant chemotherapy when the T size is 2 or more than 2 centimeter. So almost 70 plus percentage of medical oncologists were agreed with at least 2 centimeters should be the primary tumor size. For T1C, if surgeon has referred for neoadjuvant therapy, I'll not use pembrolizumab in that setting. I'll definitely use the chemotherapy backbone, that is AC followed by taxane, and I'll refer them to surgeon for surgery further.
What about carboplatin? Will you use or will you not use carboplatin?
I'll use carboplatin, Shikhar. Yeah.
Okay. Satish, Dr. Satish, what about you? Do you
Yeah,
agree?
correct.
Gunjesh?
I agree. We should not undermine chemotherapy because before pembrolizumab, also patient were TNBC were getting treated, and it was because of chemotherapy alone. And I think I'm very comfortable with chemotherapy only. Immunotherapy, since the trial didn't include, I will not probably I'll not include it.
Probably. So both of you would probably not include pembrolizumab
Pembro.
in this T1C N0 setting. Okay. So both of you are agreeing with each other. What about Manavi? Manavi? I don't think I can.
Yes, sir. Yes, sir. I also agree with them, sir.
So none of the panelists would want to use pembrolizumab in a T1C N0 and go strictly as per the trial eligibility criteria. Am I right?
Correct.
Okay. And the chemotherapy backbone, all have agreed that they would use AC followed by would you start with AC or would you go with first taxane platinum and then go for AC EC? What is it that you do in your practice, Gunjesh?
Conventionally, AC followed by taxane and carboplatin.
Okay, first you start with AC regimen.
Yes.
Satish, what do you do? Do you
Yeah.
do it?
Same, sir. AC followed by Paclitaxel.
Okay. So, yes, Manavi, do you have any opinion, Manavi?
No, sir. I also go with the same. Either we can give either AC followed by Paclitaxel or Paclitaxel followed by AC. Doesn't matter much.
Okay. Okay. So when you use carboplatin, do you go for weekly carboplatin, Manavi, or do you go for 3 weekly carboplatin?
Sir, if the patient is elderly and if she's frail, then I will go for weekly. And otherwise, if she's fit and young, then 3 weekly. Because, sir, they come from faraway places. So it's very difficult.
Correct. I think weekly carboplatin is something which is very difficult to convince the patient because of the number of sessions which increases drastically with weekly carboplatin. Okay, so if you look at the like how Gunjesh was mentioning about the Galen consensus, so this is what I found interesting, that even though a patient with a T1C node negative disease would not fit into the keynote criteria, still around almost close to 45-46% patient of the panelists, they voted that they would use pembrolizumab. So I think that is how people get this is how people think, and this is what we should keep in mind, that there are plenty of oncologists there who would probably stretch the criteria in the real world setting and not stick as per the strictly protocol defined inclusion criteria. But yeah, I think I agree with the panelists that as far as possible one should try to stick to the landmark trials inclusion and exclusion criteria, because then only you can actually achieve the results which have been demonstrated in those key trials.
So Shikhar, what you did? Hello, sorry, Shikhar, what you did in your patient, and how you
moderator
justify?
से क्वेश्चन कैसे पूछ रहा है भाई?
अरे नहीं, Dr. Shikhar is
Rules break
Dr.
थोड़ी ना कर रहा है.
Moderator has to ask the
No,
question.
just I want opinion from moderator also, because he has treated one patient there in Hyderabad in Yashoda Hospital. So
No.
what was his opinion and how he
यशोदा में
treated
तो
that?
they will use pembrolizumab क्योंकि बोलेंगे भाई इतना सस्ता दवाई दे रहा है, ये ठीक नहीं कर रहे हैं, ठीक
The
डॉक्टर नहीं है.
patient did not take treatment with us and went away for another opinion. Okay.
Okay. So Shikhar, sorry, but what you advised? Did you advise for pembrolizumab with that patient?
I did advise.
Okay.
Because she was a very young lady, maybe around in her mid-30s. ECOG PS0, mid 30s and financial.
Shikhar, the patient here are so poor. The moment you will see T1C, you will be feel very happy that you don't have to counsel for pembrolizumab. So
I
your
know.
headache is gone.
This is
But when you have a rich patient, so you're like, okay, oh, your friend will go towards PP. Okay, can he afford? Can he afford? Can we have more criteria?
Definitely. So no, we will talk about the science. The practical realities that we face in our world is something which is an entirely different discussion altogether. So yeah. So again, the panelists in this Galen conference, again, they were split between using weekly Taxol Platinum versus 3 weekly Taxol Platinum. So that is, I think, fair enough. Now, coming to the next important question, you have started the treatment with, say, with Keynote 522 protocol, and the patient is a germline BRCA negative, and now you're unfortunately, see, the PCR rates, if I'm not mistaken, were somewhere around 60 to 65% with this regimen. That means 1 in 3 patients will not achieve PCR despite this. So what would you do, Gunjesh, if PCR is not achieved in your patient?
With PCR not achieved, definitely adjuvant pembrolizumab I'll give. And I think in the trial they have used for 9 cycles, I'll give for 9 cycles.
So you will stick to only adjuvant pembrolizumab. You will not choose the blue or the green box.
No adjuvant capecitabine, because I don't think they have used capecitabine adjuvant along
That
with.
is why the trial did not in its protocol mandate the use of capecitabine, because that was a different thing altogether. That was not included in the trial scheme at all. That is why we are discussing about the real world challenging scenarios, because we have to extrapolate from different trials and see what to do in our patient. So, Dr. Satish, you agree
So
with
I have 2 patients. Like I have given pembro for 5 patients. 2 have not received PATCR. So I have added capecitabine in those patients because the PATCR what they have achieved, it was initially T4N1 and what is this T2N1. So certainly some part of chemotherapy has not worked or carboplatin has not worked. So in both of my patients, I have used pembro plus capecitabine.
So you have chosen pembro plus capecitabine.
Plus capecitabine.
Okay, that's interesting. So finally, we have some difference of opinion. Manavi, what would you do?
Sir, I would just like to say, sir, irrespective of this PATCR, whether we achieve it or whether we don't achieve, we have to give adjuvant pembro, right?
Correct.
So that doesn't matter whether we have achieved it or not. So why
Okay.
is
No.
the
What was I was trying to tell? Ki the biology is with carboplatin and pembrolizumab we are giving NNCT, but your tumor has not responded. Probably it is biology is not good. So probably I'll try with some capecitabine with immunotherapy.
Yeah.
So there is no doubt that without PATCR, with PATCR, pembrolizumab has to be given. But if the PATCR is not achieved, like 1 in 3 patients, so definitely it's a little biology is different than the rest of the tumors.
Okay. So Manavi, what would you do? You have to choose one of these 3 options.
Sir, I will add a capecitabine because triple negative, the patient is triple negative, then anyways, she's going to relapse. So
Okay.
for the benefit of doubt, I'll give.
Okay. So for the
So
benefit of doubt,
I had like 2 patients, 2 or 3 patients. We have 3 patients we are reporting primary platinum resistant. And when we added immunotherapy also, there was hardly any response.
Okay.
So I just want to add something, because the data of adjuvant capecitabine is not that strong. If I'm not wrong, only one trial showed benefit, but while another was negative. So again, the role of adjuvant capecitabine in those patients who have not received PCR in TNBC is not that good. Definitely, we don't have much option. We don't have much option because BRCA is negative. So definitely we can add, but maybe I'll stick to pembrolizumab only.
Okay. So let's again look at what the Galen team of panelists would do. So the majority of panel members, I think almost 75%, they would administer adjuvant pembrolizumab with capecitabine. So again,
So I think Satish must be there in that.
So there is no hard.
No, but it is difficult. I'll tell you. I had one patient of pembrolizumab not received TNBC. But when it relapsed, madam, the first patient of immunotherapy which relapsed, which I told I had added capecitabine, irrespective of that, it relapsed. He went opinion XYZ. I'll tell you off the record, everyone would have advised pembrol plus capecitabine. And then when I've written pembrol plus, all the big shots you name, they had advised the same thing. So then he came to me after 2 months and he told me, sir, ye bhi advice sab jagah se kiya tha. So TNBC, if it is a bad pathology, probably I'll go with whatever I have.
Yeah, so I think that is what this was a similar thought amongst the panelists in this Galen conference as well. So probably it's more out of maybe desperation rather than any hardcore evidence as of today. But yeah, the at least the important thing to note is that the toxicity is not overlapping between
Yes,
pembrolizumab and
that's correct.
capecitabine.
The toxicity doesn't add up. So
Yes.
I discuss with the patients and then we
Yes.
start.
Yes.
And you don't need you will not have a fair trial between Pembro and when capecitabine arm is nobody will fund that.
Yes. Yes, I don't think that trial will ever happen. So probably it's just
That will trial will never happen because capecitabine, who's going to fund for capecitabine in front of MSD?
yes. Okay, so now the other way around, if your PCR is not achieved and germline BRCA is positive, so now Gunjesh, what would you do? Would you would you do something else, or give only adjuvant pembrolizumab?
Good question. So I'll add olaparib. I'll add olaparib along with pembrolizumab.
So
Definitely.
now you are willing to add adjuvant olaparib.
Yes,
So
yes,
you don't like capecitabine, but you like olaparib.
Because again, I was not very convinced. I am not very convinced with capecitabine adjuvant. I don't think in real world scenario it is helping us much. But if we have some targeted agents, then definitely we should add along with the immunotherapy.
Okay, Dr. Satish, I
So
think you
I will go with
add
Pembro plus olaparib.
Okay, Manavi.
Yes, sir. I'll add olaparib with pembrolizumab.
So everyone loves olaparib. Okay, so again, here also, most of the panelists, I think 2/3 of panelists, they think that I think they also agree with our esteemed panelists. 2/3 would add olaparib with adjuvant pembrolizumab, although not a standard as clearly written, but it is possible and the safety also seems to be acceptable.
See, now you see that Pembrolizumab plus olaparib is not standard, but it can be added. But you see, capecitabine another is a poor man's choice.
Exactly, exactly.
So nobody loves the poor man.
Okay, another interesting question. Now that we have that our market is going to be flooded with generics, and you already have Dr. Reddy's launching toripalimab at a fraction of the cost, which appears to be as good as pembrolizumab in multiple indications already. Would you be comfortable substituting pembrolizumab with any other checkpoint inhibitor as far as this early TNBC is concerned? Dr. Satish, you were worried about
early TNBC. I would not add those curable malignancy. I will not add pembrolizumab. I will not substitute. But I have used toripalimab in GE junction in 2 of my patients. And one of the patient, I think Dr. Gunjesh, they would have shown him report. He has presented in recently this Ranchi Cancer Summit, and this patient got more.
Sorry, I think
more than partial response.
Okay.
Hello.
Yes. Okay. So you would.
So I had 2 patients on toripalimab, G junction, very good response.
No, I'm talking about this indication, Dr. Sir. TNBC, early TNBC.
No, I told I will not add. Like curable malignancy, I will not experiment.
Okay, Gunjesh, what about you? Would you be tempted if patient says, no, sir, I can spend 1 lakh, 1.5 lakhs, but not 2 lakhs, 3 lakhs?
See, I am using because some of our seniors from CMC Vellore are using low dose nivolumab also in neoadjuvant setting. So definitely I am giving neoadjuvant nivolumab 40 mg along with chemotherapy, and they are running a trial also in CMC Vellore. So definitely
Okay.
Yeah. So I'm using the low dose nivolumab along with chemotherapy.
You are using. Okay. That too not standard dose. Okay. Manavi, what about you?
No, sir. I won't substitute any other checkpoint inhibitor with pembrolizumab for triple negative response.
It's very interesting because another similar trial was done just like Keynote 522. If you see, very similar design, again T1C positive or T2 and above, same endpoint EFS, again multi-center large phase 3 randomized trial, again same backbone arm, taxane platinum ACEC surgery versus this time it was atezolizumab. Again, atezolizumab added to the neoadjuvant and adjuvant phase, and it was a large trial, mind you. As you can see, the patient numbers, it was quite good. It was a 1,000+ patient trial, and unfortunately, the event-free survival was negative. So the primary endpoint, as you can see, the p-value was 0.8. It was not significant. There was no significant OS benefit. The PCR, again, there was a slight increase in PCR, numerical increase in PCR by around 6 to 7%. But even the OS again was negative. So both the EFS and OS was negative with atezolizumab. And this trial is buried. No one, I think hardly anyone of us ever came across this trial in our routine academic discussions. But this is how it happens. Negative trials get buried and positive trials get all the limelight. So I think, yes, whether you can substitute one immune checkpoint inhibitor with another, we are learning slowly and steadily that that is not the case. We just cannot replace one drug with another because many of the times one drug comes negative and another drug comes positive, and we have seen this across multiple solid tumor types. So that was just a point I wanted to make across.
So, Shikhar, cost was an important point because you have asked that toripalimab is of low cost and nivolumab generic is coming. So, if it is available in low cost, then definitely we can substitute. No, we don't have data.
That's what
So
I'm
at
saying.
least,
So even
yeah.
with the full dose of a alternate immune checkpoint inhibitor, I know atezolizumab is like the black sheep of the immune checkpoint inhibitor family because it has failed in multiple indications where
In multiple indications, correct? Yes.
I know that, I'm aware of that, but just a point which I wanted to bring across that it's not sometimes always interchangeable. So just coming to the final discussion, we'll wrap it up quickly. I think already Dr. Nihanti, she presented the ASCENT-04 trial. Very interesting. Metastatic TNBC, which is, we know, a very aggressive disease. The median survival is not more than 1 to 1.5 years in many cases. Do you agree with the PFS as a primary endpoint, Gunjesh?
So for me, in advanced TNBC, I think overall survival should be OS should be the primary endpoint.
Yes, I think I agree with you, but let's hear our other panelists as well. Dr. Satish, what do you think? Dr. Satish? I think he's not able to hear me. Dr. Mannavi?
Yes, sir. PFS should be the primary endpoint for advanced TNBC, sir.
You agree that PFS is a good endpoint for advanced TNBC?
Sorry, sir. OS, sir. Sorry, sir.
Okay, so yeah, I think the choice of PFS as an endpoint is a little questionable in advanced TNBC, but that is the way trials are designed, and now there's not much that we can do about it. Sacituzumab govitecan is already approved in the second line and above setting in TNBC, and this trial also allowed crossover to second line sacituzumab govitecan on progression. So we will not know that whether using this drug upfront compared to using it later actually improves survival, because eventually many patients will cross over to sacituzumab in second line once they progress from the control arm. That being said, the trial did achieve its primary endpoint. So if you see the patient division, 1/3 of patients presented with de novo stage 4 disease. So keep this in mind, and the others had a recurrence after they were treated with a curative intent. Okay. And the choice of the chemo backbone. So as you can see in the control arm, it was chemo plus pembrolizumab for a CPS positive subgroup. So they took only patients with a positive CPS because the earlier trial with Keytruda showed that only this CPS more than equal to 10 subgroup, they benefit. So the chemo backbone in half of them was taxane and the other half was gemcitabine carboplatin. So just keep this in mind before we discuss the results. So as we all saw, the primary endpoint was positive. The PFS was 11.2 months on average versus 7.8 months with the control arm. So definitely there is a significant improvement in median PFS that the trial is positive in its primary endpoint. If you look at the subdivisions, now look at the subgroups of de novo disease. Very interesting. Look at the hazard ratio. I know this is a subgroup analysis, but that is what we have to do with. De novo metastatic TNBC, the difference is much more modest between the control arm and the experimental arm. Your thoughts, Gunjesh? What do you think is the difference between the reason for difference between the de novo TNBC metastatic arm and the patients who had a recurrence after treatment with curative intent?
No idea, boss, regarding this.
But it is definitely very striking, isn't it?
Yes, it's very. So I've not gone through with this trial. But this is this is very important that de novo they are not responding well. The recurrent disease, which could be a resistant or refractory kind of disease, they are responding with this combination. So that is a very
Exactly.
weird thing.
Exactly. Look at the median PFS and the patients who had recurrence after 1 year after treatment for their localized TNBC. It is 16.6 months, almost double that of control arm.
Correct.
And those patients who had de novo metastatic TNBC, it is almost there's less than a month's difference between the control arm and the experimental arm. Dr. Satish or Dr. Manavi, do you have anything to comment on this? Manavi?
Sir, I think de novo must be more aggressive than the patients who had recurrence. I'm not sure.
That's what I thought as well, that those who have de novo metastatic TNBC, they have very aggressive disease. So no matter what you do in those subgroups, those patients, they just don't do well. As
But
opposed
in
to,
general, sir, also we have seen ki when we have metastatic TNBC, or whenever we see, they generally also with normal chemo also they don't do very well. So
that's what,
maybe we need more research into the genomics.
yeah, so something very interesting. I mean, this is something which we cannot ignore. So what I'm trying to say, 1/3 of your patients were de novo stage 4. And actually, there's hardly any difference between these two arms. So something which I think so far was not highlighted in either the initial presentation in the ASCO, as well as so far I have never not seen anyone highlighting this point. Something which struck me when I was just going through this trial, when I was preparing for this panel. So in anyhow, and the another thing which struck me was that again, the choice of the chemotherapy backbone also made a lot of difference. If you see the benefit was more marked in those patients who received gemcitabine carboplatin as a chemo backbone in the control arm, as opposed to those patients who received taxane. And I think most of us, we actually use taxane as a chemo backbone with pembrolizumab. Dr. Gunjesh, do you use taxane or do you use something else?
So taxane mostly, and in the second line maybe we can use
Exactly.
gemcitabine.
Exactly. So yeah, the benefit again seems to be more in the gemcarbo base. Basically, maybe is it a inferior combination compared to taxane? We don't know, but something to think about.
So these are the chemotherapy before randomization, no? Not along with the chemotherapy along with pembrolizumab. So before randomization, I think when they presented de novo and then they recurred. So initially they have received gemcitabine carbo
No,
or
no.
taxane.
This is the choice of the chemo which the control arm received. Control arm received either gemcarbo or taxane with pembrolizumab,
Okay, fine.
not the previous treatment. Okay. Okay, so I think that is the end of my panel. I think we learned a few things. We learned that Gunjesh doesn't like capecitabine, and everyone loves olaparib. And yeah, I mean, it's something interesting to think about. But I think, yeah, we would be, most of us would probably, be a little bit skeptical regarding TNBC when the patients don't achieve PATCR. We would try to add whatever we have in our hand. And as far as Ascent O4 is concerned, I think the primary endpoint, I don't at least agree with PFS as a primary endpoint. OS would have been a better endpoint in this very aggressive disease. And something to think about the subgroup of de novo patients not having any significant benefit with this combination of sacituzumab plus pembrolizumab. Thank you so much. Thank you, my panelists. And if there's anything else we can talk about.
Yeah. My question, Shikhar and Satish Manvi is there. So if patient has achieved PATCR with pembro and chemotherapy, would you like to continue with this pembrolizumab in adjuvant setting, or de-escalation is okay with it? Because one trial is again going on, the result is
Yes,
will
yes.
come in.
Until that trial comes, actually, no one knows. If you look at the 5-year, the updated data, the difference in OS is 2%,
Yes.
94% versus 92%. So that the benefit is not very marked. But again, if you are going as per what the trial has done, you have to give it. Anyhow, we know with the Kiran program, the remaining doses, they do come free. So that at least financial toxicity definitely comes down. There's only the added toxicity of coming to the hospital and taking the infusions. But until the ongoing trial data comes, I think most of us would continue the adjuvant pembrolizumab. Dr. Satish can add to that. Do we have any more time left, or I think the time is over?
Hello? Yes, sir, you can have a discussion, 5
Yes,
minutes.
so
Sorry. I didn't get your question, sir.
So what Dr. Gunjesh asked, if you achieve patch CR, would you want to de-escalate and stop the adjuvant Keytruda there, or continue adjuvant Keytruda as per the trial?
So I think I'll continue adjuvant Keytruda until unless the toxicity or something else happens to the patient. Otherwise, by the trial I'll continue Keytruda.
No, no,
Even the
because in
patient.
our we were discussing regarding pertuzumab, regarding affinity trial, subgroup analysis, only node positive patient benefited, overall survival and everything. So again, that's why I'm asking ki those patients who have achieved PAT-CR, and in those population subgroup analysis, they have shown that there is the hazard ratio was not that significant. So again, we are okay with continuing pembrolizumab in those patients also who have achieved PAT-CR,
So that's what
isn't it?
where TNBC is a very tricky disease. Moment you stop anything, and with the highest chance of recurrence, why you want to take a risk and deviate out of the trial? So rather, I'll continue pembrolizumab, where I will be probably safe, and the patient also get if he is affording pembrolizumab in NACT, there's no point that we'll stop him in adjuvant when we have Kiran and all that. Tomorrow,
This is
after 3 months, the
patent Dr.
recurrence
Sachin's
happens.
line.
He will hold your collar and tell me ki why you have stopped pembrolizumab when it was you are starting your own protocol. Who has told you to judge it? See, trastuzumab, pertuzumab again is a different thing, because see, we know that people who are taking Pertu, we are pushing for it. Okay, let's go. The response will be better, but not most of the 99% of the people who are affording pembrolizumab in NACT, they are well-to-do. So I don't think it ever crosses your mind whether somebody achieving PATS-CR that I'll stop.
Okay, point well taken. So I think let's conclude our panel, and thank you, Gunjesh, once again, and all the best for the rest of your virtual meeting.
Thank you, Sekar sir.
Thank you, sir. Thank you, everyone, for the excellent panel discussion. And as we move forward for the lungs,
Sudeep sir, can you hear me? Yeah.
Yeah, thank you, Dr. Gunjesh, for inviting me. I was listening to my friend, Dr. Somnath Rai. So I'll be briefly speaking on present and future landscape of HER2 positive breast cancer management. And my focus will be in early breast cancer. So all know that breast cancer is the most common cancer in Indian patients. If you combine both male and female gender. And of course, this is the most common cancer in women as well. In 2025, this is the prediction of new cancer cases. So, there is a incidence of HER2 positivity. 20 to 25% of breast cancer patients have tumors that are HER2 positive, and they are eligible for HER2 directed therapy. Let's talk about what is the present landscape of HER2 positive breast cancer management in early breast cancer. So there is role of HER2 directed therapy in neoadjuvant and adjuvant setting. The breast cancer where we consider neoadjuvant therapy across all the molecular subtypes will be high tumor volume to breast ratio to achieve a higher breast conservation rate, lymph node positive disease, particularly two molecular types, TNBC and HER2 positive breast cancer, and young age at diagnosis, which are biologically, their behavior is very aggressive. If you analyze HER2 positive early breast cancer, then the indication will be any disease which has node positive or the tumor size is more than 2 centimeter. What are the landmark trials in neoadjuvant setting? One is Neosphere study. In a Neosphere study, there were 4 arms, and all the 4 arms, they had neoadjuvant HER2-directed therapy, 4 cycles of taxane plus trastuzumab, or 4 cycles of taxane plus dual HER2, or trastuzumab plus pertuzumab 4 cycle, and trastuzumab plus pertuzumab 4 cycle followed by surgery. And then patient received 3 cycles of anthracycline, which is FEC, followed by 1 year of trastuzumab maintenance. To note here that here the adjuvant part, the maintenance part constitute only trastuzumab, not a trastuzumab plus pertuzumab combination. And the primary endpoint was PathCR rate. Another landmark trial was Triphiana study. This is a phase 2 study. And this trial had 3 arms. Now here, if you look at the outcome, the Neosphere trial, THP, that is trastuzumab, pertuzumab, and taxane. This arm achieved the highest PathCR rate, which was 46%. And in phase 2 Triphiana, look at the phenomenal PathCR rate with TCHP. This TCHP regimen was anthracycline-free regimen, 6 cycles of taxane, carboplatin, trastuzumab, and pertuzumab were administered, and this regimen was anthracycline-free regimen, and the patient achieved 63% PathCR rate. So in NCCN guideline 2025, also they have mentioned TCHP regimen as one of the preferred regimen. What are the other preferred category 1 regimen in neoadjuvant setting? One is Neosphere regimen, that is TCH, and TCH, that is docetaxel, carboplatin, and trastuzumab. Patients can be also treated with paclitaxel weekly and 12 weeks of trastuzumab weekly, which is kind of modification of Dana-Farber adjuvant regimen. So all preferred are actually no anthracycline regimen. This is the future landscape. This Fargen study design is very interesting, but it is a complex study design. It is a phase 2 trial. And the objective of this trial was to select out some of the patients who have a biologically good behavior disease, who were treated with only HER2-directed therapy and like 2 cycles of trastuzumab and pertuzumab in group B, and then followed by a response PET-CT scan. And if there was a response, then they will be treated with only HER2-directed therapy only if they achieve PathCR. And this way we can actually avoid chemotherapy. So a PET response after cycle 2 in group B was 79.6%, and the as per the 3-year IDFS, look at the 3-year IDFS in group B, that was phenomenal, which is 95.4%. And group B without chemotherapy, of course, if patient did not achieve PathCR, then they will be treated with chemotherapy. It will, the 3-year IDFS rate was 98.8%. These are the safety analysis, safety features. So they concluded that with a 3-year IDFS of 98.8% among patients with PET response and after surgery PathCR treated solely with trastuzumab and pertuzumab based therapy without any chemotherapy, So this trial identifies approximately 1 in 3 patients with HER2 positive early breast cancer who can safely omit chemotherapy. Now, coming to the role of adjuvant HER2-directed therapy, we all know landmark phase 3 affinity trial. Here, patients who are node positive or node negative, but the primary tumor size was more than 1 centimeter, they after surgery, they were randomized into chemotherapy plus trastuzumab and pertuzumab versus chemotherapy plus trastuzumab only. And the primary endpoint was IDFS. So in the whole cohort, there is no difference in IDFS. Look at 8-year, there is no ways benefit. Look at 8 years, the overall survival was pretty same. And in intention to treat population, the 8 years IDFS rates were slightly on the higher side of dual HER2 blockade, but the magnitude of benefit delta was not clinically meaningful. It was 2.6% only. However, this magnitude of benefit of in IDFS were more prominent in node-positive disease, where the 8-year IDFS was 4.9%. So it makes sense to treat patients who did not receive a neoadjuvant chemotherapy and upfront surgery is done and there is node positive. So they are eligible for dual trastuzumab pertuzumab based adjuvant therapy. It is also incorporated in NCCN guideline, and there is a soft indication in patients who are node negative but T2, T3. So this is the NCCN guideline version 2025 that you start with HER2-directed therapy plus chemotherapy. If the patient had PATH CR, then you treat them with trastuzumab plus minus pertuzumab, particularly if the patient was node positive at initial staging. And if the patient is hormone receptor positive, then you need to add AI or tamoxifen as far as the patient's menopausal status. This is a phase 3 Peony trial, neoadjuvant adjuvant pertuzumab in HER2 positive early breast cancer, final analysis. So this was a multicentric double-blind placebo-controlled trial. Patients who are early breast cancer T2 or T3, N0 or N1 or locally advanced, they were eligible in this trial, and they were randomized into 4 cycles of pertuzumab, trastuzumab or docetaxel, or trastuzumab and docetaxel only, followed by surgery, and after surgery they all were treated with 3 cycles of FEC. And in Trastuzumab plus pertuzumab arm, patients received Trastuzumab plus pertuzumab 13 cycle, and in control arm, patient received trastuzumab only. So total pathological complete response PCR rate was 39% in pertuzumab group versus 21.8% placebo group. 5-year DFS rate was also superior, 86% in pertuzumab group. This is Destiny Breast 05, early breast cancer with residual disease in breast and locoregional nodes following neoadjuvant therapy. They were randomized into TDXD versus TDM1, which is the present standard of care as far as Catherine trial. This is another trial which is Compass HER2, where HER2 positive breast cancer stage 2 or stage 3 patients newly diagnosed, they were treated with THP 4 cycles plus trastuzumab pertuzumab followed by surgery. and complete 1 year of HP with no further chemotherapy. Coming to metastatic setting, we all are aware of landmark trial of Cleopatra, which showed clear-cut benefit of adding pertuzumab along with taxane plus trastuzumab. There is significant PFS as well as OS benefit. This is the first trial, even in stage 4 breast cancer, HER2 positive, showed a median overall survival almost touching 5 years. So median OS was 57 months. So this is the schema of how to treat patients of metastatic breast cancer who are HER2 positive. So THP 6 to 8 cycle followed by trastuzumab pertuzumab until disease progression. And if patient had active CNS metastasis, then tucatinib, capecitabine, trastuzumab. If no CNS metastasis or stable brain mets, then TDXT. This is trastuzumab, pertuzumab plus eribulin in first line HER2 positive MBC. This trial showed there was a PFS. The PFS was hazard ratio was 0.95 and overall survival hazard ratio was 1.09. This is Destiny Breast 09. Advanced or metastatic breast cancer who are HER2 positive. They were randomized into TDXD versus TDXD plus pertuzumab or THP. And none of the regimens have shown big clinical benefit compared to clinical Cleopatra regimen. So India is now privileged to have its first pertuzumab biosimilar. This is the European Breast Cancer Conference where the Indian data was presented. And this Indian data showed that Indian pertuzumab was also fairly equivalent to the original pertuzumab. So to conclude, there are substantial benefit of adding pertuzumab in neoadjuvant setting as proven by Neosphere and Trifena trial. Fargen is a phase 2 trial which will select out some of the patients who are elderly or have poor performance score, borderline performance score, who are not fit for chemotherapy, in whom we can avoid chemotherapy and treat them successfully only with dual HER2 blockade. If their response PET-CT is showing response and they achieve PAT-CR. Affinity is the adjuvant trial where there is role of adding pertuzumab in adjuvant setting, particularly in node positive patients. And you all know Cleopatra is till now the standard of care THP in metastatic setting. So with this, I want to thank you all for your patient listening. Thank you.
Thank you, Dr. Sudhir, for a wonderful presentation. Next, let's move to the lung cancer. For the next topic, I would like to invite Dr. Ramesh Kumar. He is consultant medical oncologist from Assafi Cancer Institute, Dhanbad. He will be speaking on learning from ESCO 2025. Dr. Ramesh, over to you.
Hello, good evening, everyone. I'm Dr. Ramesh from Ashafi Cancer Institute, Dhanbad. I'm presenting the learning objectives from ESCO. Is my slides visible?
Yeah, sir, they are. Just make it full screen, sir.
Yes. Is it okay?
Sir, just make it. Yeah, it's right now. Okay.
I'm having technical error. Please give me some time.
So if you want, so I can present from my side. I have your slides.
Yeah, now is it okay? Hello?
Yes, sir. Yes, sir.
Yeah.
You can move. You can move. Scroll down.
So I'm presenting the ESCO
Yes.
learnings. First trial is on the neoadjuvant nivolumab plus chemotherapy in the patient with resectable non-small cell lung cancer from Checkmate 816. In this pre-planned 5-year analysis, we will study the use of this neoadjuvant nivolumab plus chemotherapy, which is demonstrated a significant survival benefit with respect to chemo alone. And the long-term EFS benefit was also observed. Patients with the pathological complete response following the neoadjuvant nivo plus chemo had improved long-term survival as compared to without PCR. And pre-surgical circulating DNA clearance was also associated with the improved overall survival regardless of the treatment. In the phase 3 Checkmate trial, it was seen that EFS hazard ratio was about 0.63 and the PCR rates was around 24% versus 2.2% in the chemo alone arm. So Nivo plus chemo is the sole neoadjuvant only chemoimmunotherapy regimen approved in United States and European some countries. So we present this data for the 5 years follow-up. Mutations was not proven at that time and alterations was not there in this trial. So the primary analysis population was having nivolumab 360 milligram 3 weekly with chemo and chemo alone, and after that they underwent surgery within 6 weeks of treatment and adjuvant chemotherapy or radiotherapy. So median follow-up was around 68.4 months and my minimum was around 59 to 60 months. Primary endpoint was PCR and EFS. Secondary endpoint was OS and major pathological response. Exploratory analysis was done by OS with the OS and the circulating DNA clearance and lung cancer specific survival. So we can clearly see that in this Kaplan-Meier curve that the OS with the chemo arm was around 73.7 months, but in the Nivo plus chemo arm, it was not reported. And the hazard ratio was significant. It was around 0.72. If we see the subsequent anti-cancer therapies, they all received radiotherapy, surgeries, chemoimmunotherapies, VEGFR inhibitors, EGFR inhibitors, and other targeted therapies in different regimens. If we see the key subgroup analysis, we have seen that all the factors of the baseline characteristics favored Nivo plus chemo arm, except this stage 1B to 2A, in which some favors that chemo only, and in early lung cancer, and in stage 3A onwards, they favored Nivo plus chemo regimen. And in the PDL1 less than 1%, they also favored chemotherapy. And in PDL1 1 plus 1 to 49%, they favored Nivo plus chemo more than chemo alone. If we see the overall survival by the baseline stage of the disease, then we can clearly see that in stage 3 the graphs are more separated than stage 1 to 2. But the median OS with the Nivo plus chemo in the stage 1 to 2 was not reported, but in the chemo arm it was around 76%, 76 months with the hazard ratio of 0.77, and in stage 3 the hazard ratio is 0.7 with the median OS is 73.7 months. If we see the character of the PDL1 expression in PDL1 positive cases more than 1%, the median OS was around in chemo arm was around 73 months and OS was 0.5, and in PDL1 less than 1%, it was around median OS was around 61 months with the hazard ratio of around 0.89. So the lung cancer specific survival is also observed. It was not, the median OS was not reported, but the unstratified hazard ratio was there. So it was around 0.65. The EFS for 5-year analysis was seen. It was around 59.6 months in Nivo plus chemo arm and 21 months in chemo arm. OS were by PCR status obtained. It was seen that in the Nivo plus chemo arm, it was not reported at all. But in the chemo arm, with the patients who didn't achieve PCR, the median OS was around 73.7 months. So one more thing was obtained is here the circulating DNA levels. The detected circulating DNA levels at cycle 1 was around 56% in the Nivo plus chemo arm, and in 35% patients with the chemo arm had ctDNA clearance, as we can see in this graph. If we see the safety summary, they all had adverse events, but the treatment related adverse events was less in all the arms. The surgery related events were more, and treatment related deaths was almost 0 in Nivo plus chemo arm versus 3 in the chemo arm. In this pre-planned final analysis, we have a 5-year analysis. 5-year rates was OS rates was around 65% in Nivo plus chemo arm and 55% in chemo arm respectively. Nivo plus chemo showed improved lung cancer survival also, and the PCR with the Nivo plus chemo had 90% reduction in the risk of death by 5 years versus those without the PCR. The pre-surgical circulating DNA clearance was associated with the long-term OS improvement, and the safety profile was with the Nivo plus chemo was consistent with the previous reports. So we can conclude that the Checkmate 816 is the only phase 3 trial of the neoadjuvant chemoimmunotherapy to demonstrate a significant OS across any resectable solid tumor type, and it shows a paradigm shift in the treatment of resectable lung cancer without any genomic alterations. The second trial is about in the resectable EGFR mutated lung cancers, the neoadjuvant role of neoadjuvant osimertinib plus chemotherapy versus chemotherapy alone. So neoadjuvant, key point is the neoadjuvant osimertinib with or without chemotherapy should be considered as the treatment for patients with the resectable EGFR mutated lung cancers for whom neoadjuvant therapy is recommended. In the background, we know that the neoadjuvant chemotherapy and neoadjuvant chemoimmunotherapy are options for the resectable lung cancers. However, major pathological rates and with the neoadjuvant therapy are low, and the more effective treatment enables the patient to complete surgery and derive benefit of osimertinib as demonstrated in ADAURA trial. So the phase 3 NEO-ADAURA study explores whether the neoadjuvant osimertinib with the chemotherapy can further improve the pathological, surgical, and long-term outcomes in the resectable EGFR mutated stage 2 to 3 lung cancer. So in this new ADAURA trial, patients more than 18 years was taken with biopsy confirmed non-small cell lung cancer with exon 19 L8 58R mutation with the performance state 0-1, randomized into 3 groups, equal groups, and in which the first group received osimertinib with chemotherapy, second group received osimertinib alone, third group received chemotherapy alone. The baseline characters in these groups were similar. They were divided by age, sex, smoking history, histology, EGFR mutation, and the regional lymph nodes. Most of them have the N1 and 2 lymph nodes. We can see that in the group of osimertinib plus chemotherapy, 92% underwent surgery. Of them, 91% had R0 resection, whereas in the osimertinib group, 97% underwent surgery and 95% had R0 resection. And in the chemotherapy alone group, only 89% underwent surgery, of which 93% had R0 resection. So we can also see that the fewer patients have progressive disease that precludes definite surgery with both osimertinib containing regimens, such as in the osimertinib plus chemotherapy arm, surgery was done in only 90% and 95% in osimertinib arm. The major pathological rate was major pathological response rate was also statistically significantly higher in the both osimertinib containing regimens. With osimertinib and chemotherapy, there was 26% of MPR, and in osimertinib group 25% versus 2% in the chemotherapy alone. In this first plot, we have seen that the most of the characteristics favors the osimertinib plus chemotherapy arm in the first figure, and the second figure also the osimertinib monotherapy arm. No characters have crossed the midline. Over 50% of the patients with the baseline N2 disease were downstaged at the surgery with both osimertinib containing regimens, such as in the osimertinib chemotherapy arm, 53% had downstaged the N2 disease, and in the osimertinib monotherapy arm, 53% had downstage disease, while only 21% in the chemotherapy arm had decreased the N2 disease. In the interim analysis of event-free survival, the data is immature, and we have seen that the hazard ratio was around 0.50 with osimertinib plus chemotherapy arm. That is significant. Majority of adverse events reported with the osimertinib were non-serious and did not lead to the treatment discontinuation, and there was no any treatment discontinuation which was majorly reported. The safety findings were consistent with the known profiles of the individual agents, such as nausea, constipation, neutropenia were seen in the chemotherapy arms of every group, and skin rashes and other skin side effects were seen with the osimertinib arm, with the diarrhea and constipation was also seen. ILD pneumonitis was very less. Fewer have seen such kind of events. So, concluding my point, neoadjuvant osimertinib with or without chemotherapy demonstrated statistically significant improvement in the major pathological response versus chemotherapy alone, that is 26% versus 25% versus 2% in resectable stage 2 to 3 cancers. EFS was also favored the osimertinib arm. Fewer patients with the major pathological response had EFS versus patient without the major pathological response. Safety findings were consistent with the known profiles of the individual patients. Neoadjuvant osimertinib with or without chemotherapy should be considered when planning treatment for the patient with the resectable EGFR mutated lung cancers. Coming to the third study, that is lurbinectedin plus atezolizumab as the first line maintenance therapy in the patients with the extensive stage small cell lung cancer. The primary results of the phase 3 IM4 trial. So basically, the key takeaway points were IM4 demonstrated a statistically significant and clinical meaningful improvement in PFS and OS with the first line maintenance with the lurbinectedin and atezolizumab versus atezolizumab alone. The safety profile of the combination was predictable with an increased incidence of adverse events, most of which were low grade and treatment discontinuation rates were low. The combination of lurbinectedin and atezolizumab had the potential to become this new standard of care for the first line treatment of extensive stage small cell lung cancer. So in this IM4 study, the eligibility criteria includes the patients with no prior systemic therapy, no CNS metastasis. Patient number was around 600. Performance rate was 0.1. So in induction phase, they received atezolizumab plus carbo-etopo 4 cycles. And in the second screening, the eligibility include the ongoing response rates following induction therapy. The CR/PR or stable disease, the patient number was around 483. In the maintenance phase, they were randomized into two groups. First group received the lurbinectedin plus atezolizumab, and the second group received atezolizumab alone. So the primary endpoints were PFS and OS, and the secondary endpoints included PFS, ORR, response rates, and the safety, duration of response, overall response rates, and the safety. So the baseline characteristics were well randomized into these two groups. It includes age, sex, race, liver metastasis at induction, time from induction cycle, day 1 to randomization in the median months, and the response to induction therapy. So if
Dr.
we
Ramesh, sorry to interrupt. Just want to request you to conclude your talk in next minute.
okay, I'm just concluding. So in the randomization, the maintenance phase, we have seen that the PFS benefit was with the lurbinectedin and the atezolizumab was 5.4 months versus 2.1 months in the atezo arm, and the subgroup analysis favored this thing, lurbinectedin and atezo. Also, the maintenance phase, the OS was seen in around 13.2 months versus 10.6 months, and the median OS was, which we had discussed. Subgroup analysis also favored the lurbinectedin plus atezo, except the Asian race, which have also favors the atezolizumab alone, and previous PCI patients who can also favor the atezolizumab alone. All incidence was more than 10% or more in each arm. Most common were nausea, anemia, fatigue, these things. But the grade 3-4 infestations was around 6% in the lurbinectedin arm versus 5% in atezo arm. So concluding my topic, IM4 is the first phase 3 study to show the PFS and OS improvement with the first line maintenance treatment, highlighting the potential of the lurbinectedin plus atezolizumab. Thank you.
Thank you so much, Dr. Ramesh, for this amazing talk. Now, next, I would like to invite Dr. Anupam Mahanta. He is consultant medical oncologist at Health City Hospital, Guwahati. He will be presenting a talk on the nivolumab in neoadjuvant NSCLC. Dr. Anupam, over to you.
Yeah, good evening to all, and I offer my sincere thanks to all the organizer and BMS because this is study was presented in ASCO 2025 meeting. So can you share the slide, please?
So just sharing your slides in a minute, sir.
So
Sir, slides are visible.
yeah, it's visible. So thank you organizers and the BMS for the kind invitation. And this is trial is presented in ASCO meeting. Next slide. 20. This is the overall survival neoadjuvant nivo and chemo in patient with resectable NSCLC in the segment 816 trial. Next slide. And the key takeaways are in this pre-planned final 5-year analysis from segment 816 neoadjuvant nivo chemo combination demonstrated a statistically significant and clinically meaningful OS benefit versus chemo. And nivo chemo combination continued to demonstrate benefit in lung cancer specific survival versus chemo only. And that there is a durable long-term EFS benefit was observed with nivo chemo combinations. And the patients with PCR following neoadjuvant nivo and chemotherapy had improved long-term OS compared with those without PCR. So in TNBC or HER2 positive breast cancer, already different speakers has importance of PCR in overall long-term survival. This is true for early NSCLC also. And the pre-surgical ctDNA clearance was associated with improved OS regardless of the treatment. Next slide. In the background, it is a phase 3 study. Neoadjuvant nivo chemo demonstrated statistically significant and clinically meaningful improvement in EFS and PCR versus chemo in patients with resectable NSCLC. EFS was 0.60 and PCR rate is very striking, 24% for the nivo chemo comparison as compared to 2% for the chemotherapy arm only. So it is the sole neoadjuvant only chemoimmunotherapy regimen approved in all over the world, because other immunocheckpoint inhibitors like durvalumab, pembrolizumab were approved for adjuvant setting only, not in the neoadjuvant setting. So these are the minimum 5 years follow-up data were presented in ASCO 2025. Next slide. So this is the study design. Newly diagnosed resectable stage 1B, that is more than 4 centimeter, to stage 3A and C included. That is in the TNM 7 edition, ECOG PS001, no driver mutation, and were stratified by stage 1B versus 3A and the PDL1 expression. And those were primarily randomized into 1:1 ratio to receive nivo 360 mg every 2 weeks with chemotherapy combination for different squamous and non-squamous histology. And only chemo arm received every 2 weeks for 3 cycles, and they were restaging with imaging, and surgery was done within 6 weeks post-treatment, and the optional adjuvant or chemotherapy were done accordingly, and they were follow-up. And the primary endpoints, PCR by BIPR and EFS by BICR, and key secondary endpoints, overall survival, and the minimum follow-up was almost 60 months, and the median follow-up was 68.4 months. And the exploratory analysis were OS by PCR and ctDNA clearance and the lung cancer specific cancer survival. Next slide. So this is a final analysis OS with neoadjuvant chemo and nivo arm versus chemo. In the median OS for the nivo and chemo arm not disabled, and it is 73 months for the chemo only arm with a hazard ratio of 0.7. There is a 10% improvement in overall survival in chemo and immunotherapy arm. Next slide. And this is the forest plot, OS analysis by key subgroups. you can see in the Asian, it favors more, and in the female also, it is more effective, and particularly as per the stage, both early 1B, 2, and 3A were favoring combination of nivo and chemo with a almost similar hazard ratio of 0.77 and 7. And also regarding the PDL1 expression, it has been a hazard ratio of 0.89 for PDL1 less than 1%. But you can see in those with PDL1 more than 50%, there is a striking unstratified hazard ratio of 0.33, favoring nivo with chemotherapy arm. And regarding the chemotherapy, we know that cisplatin is found to be similar in both nivo and combination arm and chemotherapy arm, but carboplatin is favored in nivo and chemo arm. But in chemotherapy arm, we know that cisplatin is preferred over carboplatin. Next slide. And the OS baseline by stage of the disease, stage 1B to 2, median OS not reachable for nivo chemo arm, and it is 76 months for the chemo arm with a hazard ratio of 0.77, and there is a 5% difference in OS. For the stage 3A, median OS also not reachable for the nivo and chemo arm, and it is 73%, also almost similar, hazard ratio of 0.7. Next slide. Next slide, please. Regarding the PDL1 expression, you can see in the less than 1% that hazard ratio of 0.89, but those with PDL1 1% more expression, it is hazard ratio of 0.5. Median OS not reachable for nivo and chemo arm, and it is 73 months for the chemo only arm, and there is a 58%, 70, absolute difference of 20% in nivo and chemo arm with those with PDL1 more than 1% expression. Next slide. Coming to the lung cancer specific survival with chemo and immunotherapy arm, it is not reachable. And for the chemo arm, it is also not reachable with a hazard ratio of 0.65. Next slide. In the event-free survival 5-year analysis, for the combination of nivo chemo, it is almost 60 months, and there is a striking difference, almost 3 times more. Chemo arm only 21.1 months with a hazard ratio of 0.68. Next slide. In the exploratory analysis, OS by PCR status, in the nivo and chemo arm, among patients with PCR, death occurred in 3%, none were due to disease. But without PCR, there were a total of almost half, 62 deaths, 46%, and among that, mostly are due to the disease, 33%. Next slide. Now, EFS by PCR status in nivo and chemo arm, patient PCR 7% with disease recurrence or relapse, but among patients with no PCR, there is almost half, 42% patient had disease recurrence or relapse. Next slide. So for the overall survival by ctDNA clearance status, here you can see with the chemo and nivo arm with clearance, median OS was not disabled, and without ctDNA clearance, it is 61.5 months with a hazard ratio of 0.38. And for the chemo arm, with those with ctDNA clearance, also median OS not disabled, and it is 69.2 months with ctDNA no clearance. So hazard ratio is 0.39. So almost similar. So it has been found that clearance of ctDNA is very important in achieving long-term OS. And among patients detectable ctDNA at cycle 1, 56% in the nivo and chemo arm, and 35% patient in the chemo arm had ctDNA clearance. Next slide. Coming to the safety summary, in the both nivo and chemo arm and chemotherapy arm, it is more or less similar, and there is immunotherapy doesn't add too much toxicity to the chemotherapy arm. All adverse events, 94% any grade for the nivo chemo, and it is 98% for the chemo arm, and grade 3-4, 43% for the combination of nivo and chemo, and 45% for chemo arm. And all treatment related adverse events also similar with both nivo chemo and chemotherapy only. And regarding the treatment related death, none were reported, but in chemotherapy, 2%, 3 deaths were reported. And these are surgery related adverse events also similar with nivo chemo combination as compared to chemotherapy. And grade 5 surgery related adverse event occurred in 2 patients in the nivo and chemo arm. One is due to pulmonary embolism and aortic rupture. Both were unrelated to the study drug. Next slide. So in summary, in this pre-planned final 5-year analysis from segment 816, neoadjuvant nivo and chemotherapy demonstrated statistically significant and clinically meaningful OS benefit versus chemotherapy only. And the 5-year OS rates were 65% and 55% in the nivo chemo and chemo arms respectively. And this combination showed improved lung cancer specific survival rate versus chemo only. And the patient with PCR with neoadjuvant nivo and chemo had a 90% reduction in the risk of death by 5 years versus those without PCR. And the pre-surgical ctDNA clearance was associated with long-term overall survival improvement. And the safety profile of neoadjuvant nivo chemo combination was consistent with the previous reports. And the segment 81 is the only phase 3 trial of neoadjuvant only chemoimmunotherapy to demonstrate statistically significant OS benefit across any resectable solid tumor and affirm a paradigm shift in the treatment of resectable NSCLC without a actionable genomic alteration. Thank you.
Thank you, sir, for excellent talk. And I would request now Dr. Gunjesh for the closing remarks. Hello, Dr. Gunjesh, sir. I think sir is not around. So thank you everyone for joining. And thanks to my colleague Dhruv and Swarangi. And thank you to technical support team. Thank you everyone for joining. Good night, everyone. We'll join tomorrow at the same time.